Rounds, and I'd like to welcome everyone to the Isabelle Christensen Memorial Safety Lecture. Thanks to Dr. Dermody, Dr. Spears-Zuckerbraun, and the Department of Pediatrics for having the Isabelle Christensen Lecture here as part of Grand Rounds. And we're looking forward to a great lecture today from Dr. Bucher on the pathways of the quintuple aim, driving the optimum care experience. But first, I'd like to take a moment to thank and welcome the Christensen family who are with us here today. It's my honor to introduce the Christensen family, and we're gathered here today to honor the memory of Isabelle Christensen, their daughter. During her short life, she had 2 transplants with us here at UPMC Children's, one in 2004 and one in 2006. The first was a multivisceral transplant. The second was a kidney transplant. And tragically, Isabelle's life was cut short as a result of a medical error within our own institution, an error which was described by her mother, Michelle, as senseless, wrong, and heartbreaking. The Christensen family, to their immense credit, have been steadfast supporters of improving our culture of patient safety here at Children's Hospital, and have continued, in addition to founding this lecture in 2011. Michelle actually serves on our Clinical Quality Oversight Committee, where we work with patient quality and patient safety. And also Maddie, who's joining us here today, Isabelle's sister, is a nurse here at Children's and also over at McGee. And she's very passionate about sharing Izzy's story so that all of us can learn from Izzy's story and improve our culture of patient safety and reduce and eliminate harm events here at Children's Hospital. With that, I'd like to turn the mic over to Maddie and Michelle Christensen, and I'm going to share a video about Izzy, and they're going to share Izzy's story with us. Michelle and Maddie.
Thanks. Hi, thank you for having us, and thank you all for attending the lecture and having this annual seminar in memory of Isabelle. Today is St. Patrick's Day, a day where we talk about luck. Today also starts the March Madness basketball games, a day when lots of underdog teams hope to have the luck to knock off their opponents and upset your brackets. But all of those basketball teams who are competing today can't rely on luck alone. They must work together to play as a team, execute their plan, adjust when their plan isn't working, and trust that the hours put into training, preparing, for practicing and reviewing film will result in their desired outcome. Just like all of those teams, you as a healthcare professional are a team that must work together. Function as a team, execute your plan, adjust when that plan isn't working, and trust your preparation will result in the desired outcomes for your patients. Each and every one of you, no matter your role or responsibility within the healthcare system, is critical to finding success in the effort to save lives by preventing medical mistakes and promoting patient safety. This patient safety conference is held each year in memory of our daughter, Isabelle, who died as a result of a medical mistake. Izzy was a transplant recipient who went from being TPN dependent to loving Chinese and Mexican food, loving the movie Annie, eating giant pieces of cake, and loved playing dolls and pretending she was the mom and a doctor to all of her dolls. Tragically, though, her life was cut short at just 10.5 years old, when a fatal dose of IV potassium was administered instead of the prescribed dose, and our world came crashing down. 1 week from today is Isabelle's birthday. We will celebrate with cake, balloons, her favorite restaurant, just as we always do. But there won't be any presents wrapped for her to open, and her spot at the table will be empty, just like it is every single day. It is easy to think that a medical mistake ended her life, but it isn't that simple. For our family, the incorrect concentration of IV potassium being administered to Isabelle is present for us in every family gathering, at every meal, every photograph, every birthday, and even missing her sister's wedding. We can't ever get enough from that impact, and yet we try to focus on who Isabelle was and how she lived her incredible life as opposed to how she died. And so, as you move forward today and the days ahead, I would like to ask you to do a few things in honor and memory of Isabelle. Please pay attention at work. Notice the details of what is happening when you're exhausted, especially when you're tired. If you see something that is close call, draw extra attention to yourself and others. There is no better way to prevent a medical error than by honestly looking at all of the different scenarios and that are happening and making a plan for how to adjust so it doesn't happen again in the future. And please pay attention at home. The next time you are gathered with your loved ones around a table or at a birthday, pause and look around at those you love. Remember that all of you are able to be gathered together because of all the things which went right, all of the mistakes that didn't happen, and know that somewhere there are other families who are also able to celebrate together with their own families because of all the hard work that you do. As much as I wish it was possible, nothing can bring Isabelle back to our family. But if you are actively working to prevent medical mistakes and honoring the precious moments that are possible for all families, including your own, when medical errors don't happen, those are the ultimate gifts. For Isabelle, as a mom, it is the only gift I can hope and she receives this year because it isn't about luck. It is about attention to detail and preparation. I am glad that all of you are here today and participating in this conference. It helps to be able to share stories about Izzy and the things that she loved. I have the honor of introducing Maddie, my lovely daughter, who is my oldest, Izzy's beloved big sister. Maddie makes me proud by how she lives her life on days like today, and I know without a doubt that Izzy is cheering her on too. I am proud to turn the presentation over to Maddie now. Thank you.
Good morning, everyone. My name's Maddie. I'm a nurse at UPMC. Isabelle passed away from medical error at Children's, as we've said. For those of you that do not know Isabelle or her story, she was born with a mitochondrial disease and pseudoobstruction. She required 2 transplants during her short life. One in 2004, when she was 6 years old. She received a stomach, liver, small bowel, pancreas, and duodenum. And then in 2006, she received a kidney. Isabelle's transplants were her gift of life, and even at such a young age, she was a strong advocate for organ donation and looking out for others. But to me, she was just my little sister. Izzy was spunky, smart, feisty, caring, and thoughtful. Isabelle looked up to me as her big sister, but more importantly, I looked up to her. She was and still is an inspiration to me because she was such a strong person. She always brightened up my day and put a smile on everyone's face. If you ever had the chance to meet Isabelle, she probably changed your life in some small way. Isabelle was just 10 and a half years old when she passed away from an incorrect dose of IV potassium. I was 12 at the time. It was hard to put my feelings of losing my sister's death into words. It still is. Losing a sibling is a loss that is so different from any other, and no one can truly understand that loss unless they've gone through it themselves. When Isabelle passed away, my entire world flipped upside down. She had finally gotten over the stroke she just had and was her normal self again. The day before everything happened, Isabelle and I were in our driveway hula hooping and drawing chalk. I have a picture from us that day, grinning ear to ear. It was a great day, but we had no clue what was about to happen the next 2 days. On August 11th, 2008, my family's lives changed forever. What happened over those next few days sticks in my mind so vividly. Isabelle was scheduled to go to the hospital for routine blood work, but ended up getting an infusion of IV potassium since it was low. I was headed out of town with friends when I got a call that I needed to head to the hospital immediately. At such a young age, it was hard for me to understand what was happening when I arrived at the hospital. Isabelle was hooked up to the ventilator and it looked like she was sleeping. She was surrounded by family, nurses, and doctors. I was told Isabelle wouldn't make it. After we removed Isabelle from the ventilator, someone kindly asked me if I wanted to get her handprints. They were made out of clay, and the entire time we were doing them, she kept scrunching her hand and messing them up, making it hard to get her handprint. During those moments, I thought the doctors were wrong. That was just Isabelle's feisty personality showing through. Everyone kept reassuring me that there was nothing that would happen. We ended up bringing her home from the hospital to pass away peacefully. While Izzy was home for the short time, she would say the words "mom" and "drink" in a very screechy voice, so I thought she was turning the corner. There was not a day that would go by that Isabelle could not have her Diet Coke. Sometimes I wish we would have done more, but ultimately there was nothing we could have done. She passed away on August 13th, 2008, at 6:13, surrounded by her family. Life is so different today without Isabelle by her side. As my mom said, she'd be turning 24 next week, and I got married last year and didn't have my best friend to stand by my side. My younger sister, Ari, and my husband, Eric, will never get to meet her. They will only know Isabelle through the stories we tell of her because of one mistake that changed our family's lives forever. Because of Izzy, I am now a pediatric and a NICU nurse. I'm constantly giving medications, vaccines, or helping with procedures, or if I'm not double checking orders or following policies, something can go wrong. Having a personal connection to a patient safety event makes me ever so cautious in my day-to-day work as a nurse. Being a healthcare provider means our patients trust us with their lives. We see them when they are most vulnerable. Patients trust us because they know that we can help them. My family was failed by a system that we trusted. How would you feel if the people you trusted most in your lives failed you? My family doesn't point fingers for anything that happened with Isabelle's death. We learned lessons from what happened and came out with a positive attitude, because in the end, there was nothing we could do but continue her legacy, which is what Isabelle would have wanted. Everyone makes mistakes, but everyone also learns from their mistakes. It's my job as a nurse to stop the mistakes from happening if I see something. I see minor mistakes happening in my job as a nurse from time to time. I could see a wrong order being put in or TPN not having a double sign-off. Some of the mistakes that happen are because the system has failed us, or others are because we just may not be taking our time. All of us in healthcare must be open and honest about them. That's why at UPMC, a just culture is something we have, where we are encouraged to speak up about our mistakes or our almost mistakes. If we speak up about them, it creates an opportunity for us and everyone else to learn and possibly prevent something from happening. Even today, almost 14 years later, the pain, sadness, and confusion of my sister's death is still a part of my everyday life. I still struggle to comprehend how a routine blood draw turned into a medical error of giving Izzy a fatal dose of potassium. There have been many times when I think how she begged me to go to the hospital with her that morning, but I told her no. I often think I should have gone to the hospital that morning because I could have prevented what happened. But the reality is, as her sister, all my love could not have prevented Isabelle's death. But as hospital practitioners, every day, it is everyone's responsibility to prevent medical errors. Isabelle missed out on an amazing journey called life because of a mistake. I urge everyone here to always double and triple check everything you do, because one little mistake could change the lives of others forever. Thank you so much.
Michelle and Maddie, thank you very much for sharing Izzy's story with us. And just an incredibly important reminder and deeply personal reminder for you to share with us on a yearly basis of all of our individual and collective responsibility for keeping our patients safe. We appreciate you. And again, thank you so much for your time and for coming year after year to assist us in improving our culture of patient safety here at Children's Hospital.
Well, thank
Thank you
you
for
again
having
for
us.
having us and doing the lecture. It means a lot.
I'd like to now introduce Dr. Andrew Bucher, who will be presenting Pathways of the Quintuple Aim, Driving the Optimum Care Experience. Dr. Bucher is the Medical Director for Clinical Resource Management here at UPMC Children's. And in that role, he oversees the development and implementation of our clinical pathways. We currently have over 200 clinical pathways and guidelines covering both medical and surgical care here at UPMC Children's, including primary care, emergency department, inpatient, critical care, and also community and non-clinical settings such as schools. Dr. Bucher has authored textbook chapters on the development and measurement of clinical pathways, and also leads multiple hospital-level patient safety and QI projects here at Children's, in conjunction with the Healthcare Policy and Management Program with Carnegie Mellon. He's also a physician advisor for our UPMC Children's insurance denial mitigation and underutilization review functions, and also works with the Wolf Center at UPMC as an associate medical director and director for patient safety and quality improvement for UPMC medical education. Dr. Bucher, we look forward to your talk this morning, and I would like to go ahead and hand the mic over to you.
Thanks, Brian. I'm going to go ahead and share my screen. All right. Thank you, Brian, and thank you, Michelle and Maddie, for the opportunity to give this lecture today. I am absolutely humbled and completely honored to have this opportunity, and I'm most appreciative of all that you both do for us every single day with our safety and quality work here at Children's, and just incredibly appreciative of this opportunity to share with everyone today the work that we're doing here at UPMC Children's and across our pediatric service line as we use our clinical pathways to achieve the quintuple aim of quality and safety to really drive the optimum care experience. So what I am going to talk about today, and I'm going to skip over my introduction. I have no disclosures, and I just do want to mention that throughout this talk, I'm going to show a couple of screenshots from our ClickView dashboards, and we'll also mention some of our EMR packages. This is what we use here at UPMC, Cerner, and Epic, and Click, but screenshots and mentioning these certainly aren't an endorsement of these products in any way whatsoever. And so what I'm hoping to talk about over the next 35 minutes or so here is a little bit of an introduction to where we are going with quality, both here and throughout all of our hospitals, both pediatric and adult throughout the country, with the quintuple aim, which I'm going to tell you is actually a term that is hot off the press in the last 2 months from the IHI. And then specifically, I want to highlight our work with our clinical pathways here at Children's and how we're really using these pathways to drive improvement across these quality aims, and how standardization of care and standardization of communication can guide us to that. I'm going to highlight some of the work that we've done around measurement and feedback that I think has really helped us to sustain this improvement and enhance these outcomes. And then also we're going to talk about some of the collaborative relationships that we've built here. And in fact, many of you who are listening in today and watching today have been a component of this, and how this really helps us to achieve these quality aims together. So I'm going to start with a case example. So I'm going to take you back to 2013, 2014. And this was actually around the time when we started to transition from our existing clinical guidelines to the clinical pathway program that we have today. And in fact, our very first clinical pathway was our acute appendicitis pathway with our pediatric surgical group. And that happened to begin work at the end of 2014. And then throughout early 2015 happened to roll out. And as soon as we did that, we actually saw that there were significant gains in terms of decreases in length of stay, decrease in resource utilization, and enhanced outcomes, improved quality and safety of these patients. And very rapidly, there was a lot of energy around where could we build clinical pathways to expand the impact that we were seeing from appendicitis. And so our surgical group actually identified cholecystectomy patients who come in for a planned cholecystectomy as a huge opportunity. And so taking you back to 2013, 2014, these are patients that if you're a surgeon, or if you're like myself, a non-surgeon, that I take care of these patients on the hospital medicine service, and many of you may see them in your clinics as outpatients in primary care and subspecialty care. These tend to be patients who have a lot of ongoing discomfort. And what was formerly happening was that these patients would come in, they would get this procedure, they continued to have some discomfort afterwards, they ended up admitted to the hospital, and in fact, their length of stay was well over a day. Sometimes they were here for even closer to 2 days, and even approaching that 48 hours. And so after our appendicitis pathway, when we began to look at opportunities with our data, we quickly identified that when you look at this graph, you'll see that most of these patients were admitted and had longer length of stays, but there was one particular data set that showed that one set of patients was actually going home in half the time. They weren't even being admitted. They were going home in 8 to 12 hours after their procedure, as a same day procedure. And turns out that actually that subset of patients were all being taken care of by one particular surgeon who had a very unique approach with expectation setting and appropriate pain management pre-op and intra-op and post-op, and really doing some innovative work around this in partnership with a particular set of anesthesiologists, and had significant less length of stay. And these patients weren't coming back as readmissions. They weren't coming back for ER visits. And so it was a great example of positive deviance. And so we were able to learn from that and build it into a pathway that, as you can see today, these patients are rarely admitted. They're here for less than 10 hours. They go home on the same day. And it's such a great example of how our pathways can help us to drive this optimum care. So just a couple of highlights of what happens here is, with this pathway, we now provide appropriate preoperative education around what to expect and what that pre-op experience is going to be. There's actually a plan that these patients are scheduled as an early case in the morning as opposed to later in the day. And then throughout their stay, they receive the pain medications and the nausea vomiting medications with the partnership with anesthesia that help them to have rapid improvement, rapid mobility as soon as they wake up from anesthesia, and are able to be discharged with appropriate follow-up. And again, we don't see that these patients are coming back, and we don't see that they're having subsequent ER visits. And so this is such a great example of how our pathways can really help us to drive quality, safety, but also experience, and how important experience is as a patient outcome. And then also how this leads us to having an improved population health of this population of patients. So I want to talk about, for just a second here, how we got to this new topic of the quintuple aim. So back in 2008, Dr. Don Berwick from the IHI initially introduced this concept of the triple aim. And this was back in 2008. And this rapidly became a model for quality that the IHI continues to use in their work, but then also has been used by all of our organizations as we approach quality. And this really is the experience of care, which is quality and safety and patient experience, combined with population health. If we do quality work right, we keep the population of patients as healthy as possible and as safe as possible. And then doing this in a way that is efficient, where we are controlling costs very well and providing very efficient care and being very good stewards of our resources. And since 2008, most organizations have really added a fourth component to this triple aim, which is improved caregiver well-being, or the experience of those of us providing care as well. And we know, even from our own work here at UPMC, that caregivers who are well and are feel supported and feel that they have a good experience providing care contribute to enhancing the outcomes of our patients, and vice versa. When patients are getting quality care and safe care, and our patients are having a good experience in their care, that helps us as caregivers to also have our well-being that we need to have to continue to care for patients. And so very rapidly, this became the quadruple aim, which includes caregiver well-being. And hot off the press, as of January 21st, actually, the IHI has now published a commentary in JAMA proposing the evolution to the quintuple aim, which is everything that was in the triple and the quadruple aim, but also adding in health equity. As we know, the health equity is a critical component of quality, and that you can't have quality without equity, and you can't have equity without quality. And so what I want to show today is how our clinical pathway work, I think, really is driving our organization's approach to achieving each of these quality aims and really achieving the quintuple aim. Another way to say this, and this is often attributed to the Joint Commission, although no one actually knows who first coined this term, but the right care at the right time, at the right place. And I think we'll show how our pathways allow us to do that. But adding in equity, this is the right care at the right time, in the right place for everyone, always, every time. So I'm going to take you back to the beginning of our pathways journey. I mentioned around 2014 we started this work, but we actually had a really good basis to start with. our organization has actually been a leader nationally in developing evidence-based clinical effectiveness guidelines. In fact, since the early 2000s and even earlier than that, we've had a number of very well-maintained clinical effectiveness guidelines for a large number of both common as well as less common diagnoses. So our starting point was these evidence-based guidelines, although we also found that these were often very focused in settings of care. There might have been a guideline for the care of the diagnosis in the emergency department and a completely separate guideline for the care of that diagnosis in the acute care setting or the critical care setting. But there wasn't a lot of connection between, and there certainly was not a lot of connection outside of our hospital walls with including primary care and community care. And so as we envisioned where we felt that our clinical pathways program should go, we really saw an evolution of taking the existing guidelines and moving towards clinical pathways, full-fledged clinical pathways that were evidence and consensus-based, but inter-multidisciplinary as well, with a connection of the care. So the emergency department care connected to the acute care, connected to critical care, connected to outpatient care, and really encompassing the entire continuum into our pathways. We also felt that to drive this, we needed to build in measurement and feedback. And we're going to talk some of the specifics of what we do with our measurement about care that is delivered as opposed to care that was intended. And then we also felt that our pathways would really be an important way for us to drive our organizational strategy, particularly around quality and safety, building in the right care at the right time at the right place, building in ways to make it very easy to do the right thing and make it very difficult to not do the right care, and then measuring that and feeding that back. And we felt that if we did this, we would be able to not only provide higher quality, the absolute safest care and high value care for our patients and families, but also enhance their experience and enhance the experience of those of us providing care because of the building in the way to make the care the right care and make it easy to do the right thing. So as we set out along this journey, we started with defining what we thought each pathway could affect in terms of impact. And in fact, even before we began to conceptualize this into the quadruple and certainly the quintuple aim now, we thought that every pathway had definite impact along those individual patients, with that diagnosis, but also the population of those patients, that we could enhance their overall health and well-being. That might involve reducing their acute care hospitalizations, reducing their ED visits by keeping them as healthy as possible, especially for those chronic diseases. We also felt that our pathways would enhance our own organizational systems of care, that every pathway would improve the processes and the workflow for taking care of our patients. And then we felt that there would be economic impact, which is important for not just the organization, but for the healthcare system as a whole. As we know, the bucket of money for healthcare is not unlimited and never was unlimited. And we really need to be efficient and be really good stewards of the limited resources. And then we also felt that our pathways would help us with advancing our strategy around safety and quality. And so where we landed is that our pathways really have two overarching goals. The first, driving optimum care. And as we sort of see conceptually on this slide, moving from algorithms of care to building that into the EMR to make it easy to do that care that is consensus and evidence-based that we have all collectively come up with, and then providing patient and family-facing educational materials that go across the continuum so that everybody is on the same page in all settings of care, and our caregivers know what the next steps are. Our primary care providers know what those next steps are going to be when their patients are in the emergency department or are admitted. Our families know what those next steps are going to be. And so in doing so, we felt that we would be able to reduce the variation in care, which would lead to these improved outcomes, quality, safety, and financial and experience outcomes. This would enhance continuity. This would enhance communication across the continuum. And by doing this, we're providing an experience for our patients and our families that is absolutely the right care in the right time at the right place, and they feel that we are connected. And then from a provider perspective, and a nursing and physician and pharmacist and respiratory therapist, those of us who provide care, I think that when our patients and families see that we're on the same page, and I always say that we often say the same things in different ways, and when we're saying the same things in similar ways and everyone knows that we're on the same page, that helps us to feel better about what we're doing, and we don't feel that we have those awkward moments where we said the same thing as someone else just said, but we said it in a very different way, and the family is unfortunately confused and thinks that we're not on the same page. And then our second goal really is supporting and growing our population health work. And we feel that our pathways really are integral to our organization's approach to population health. And we're very fortunate to be partnered with our community health division and our primary care network via both our internal primary care network and the Pennsylvania Pediatric Health Network. And that as we expand our pathways across the continuum, this is a great vehicle to help to support the overall health and well-being of our patients and our families and keep them as healthy as possible. So I want to highlight each of the aims of the quadruple aim and provide a couple of examples of how our pathways are helping us to achieve this. And so as we start with better outcomes, quality outcomes, safety outcomes, clinical care outcomes, and patient experience, this certainly all starts with our clinical algorithms. And our algorithms are evidence-based, but also consensus-based. And in fact, the way that our team approaches this is that for any clinical algorithm, we get all the clinical stakeholders together, and that includes physicians and providers. That includes the nurses who are involved in care, the respiratory therapists, the pharmacists. This includes our primary care providers, outpatient subspecialty care, depending on the pathway, and even our school nurses. We get everyone together and we come up with the consensus for each setting of care about what that care algorithm looks like. And then we build this into an associated power plan to make it really easy to do the right thing. And this includes embedded decision support. This includes the power plan driving what's in our clinical algorithms. Most of these power plans have links to the clinical algorithm with the associated narrative materials as well to help explain why it is that we're doing what we're doing. And to continue to drive this work, we recognize that measurement is critically important, measurement and feedback of how we're doing with our clinical pathways. And in fact, as we built our dashboards to help us with our real-time measurement of how we're providing care, we actually built our dashboards and we built our measurement to focus on the care delivered as opposed to the care intended. And so I'm going to take a moment to differentiate what those are. When I think of care intended, I think about that a particular order set or power plan was used. The bronchiolitis power plan was utilized, for example. But we also know that utilizing that template power plan doesn't prevent the provider from making changes to that, nor does it necessarily mean that that's exactly what gets to the patient. And so we actually pull the care that was actually delivered to the patient. We look at the medications that were delivered, not ordered. We look at the labs that were actually resulted, not necessarily just ordered. We look at imaging studies that were resulted. And we use that care delivered to help to drive the improvement. Sometimes looking at care delivered just means that someone added something into the power plan, and there may have been a very good reason for doing that. But there are other times where understanding why care delivered was different than the care intended actually helps us to understand holes in our system, understand where we have system opportunity to improve to continue to drive the safest and highest quality care. One example I think of is a particular antibiotic that wasn't stocked on the anesthesia carts. It was constantly ordered with one of our surgical pathways, but at the point of care was always substituted with a different antibiotic. And our dashboards allowed us to very quickly recognize that and then very quickly understand what the actual challenge was, which was making sure that the appropriate antibiotic was actually stocked on the anesthesia cart so it was available at the point of care. So this is just a screenshot of our dashboard of our cellulitis and abscess pathway. And one of the things that I love about this is that we can very quickly look at each episode of care and we can understand the patients who fell off of the pathway, what it was that caused them to fall off that pathway. Imaging that's outside of the pathway imaging that we do. Doesn't mean there wasn't a good reason for doing it, but it helps us to highlight the cases that we can do a deep dive into to understand what happened. Lab draws that are outside the pathway. And in fact, one of the goals of our cellulitis and asthma and abscess pathway is to reduce blood cultures that are obtained when we really shouldn't obtain those blood cultures, because that increases the likelihood of patients having a contaminant, which increases the likelihood of needing further IV antibiotics and further blood draws and prolonging a hospitalization, all of which leads to opportunities for medical errors to happen. And it's reassuring to see that in this snapshot of the dashboard, we actually don't have any blood cultures that were obtained in patients who were on the pathway and didn't need to have a blood culture obtained. And then we feed this back to our frontline staff. And that really is critical in driving this improvement, that on a monthly, weekly, quarterly basis, and it varies based on the pathway, we're able to provide this type of data right back to the frontline care providers. And we have specific metrics that are focused on physicians and APPs. We have specific metrics that are nursing based that go to the nursing staff involved. And it allows us to have a rapid snapshot of where we're doing well and where we have opportunity to improve, and then move forward with how we improve and build an even stronger system to make sure that we're delivering the right care at the right time, at the right place for everyone every single time. Okay, so in thinking about experience, patient, family, and caregiver experience. So one of the key aspects about our clinical pathways is that everything is available on the InfoNet. And in fact, everything is searchable from whatever homepage happens to be the homepage that's on your computer or your clinical computer for InfoNet, leads right to our pathways. And this is true across the entire UPMC system. Everyone within UPMC has access to the InfoNet. And so, again, this starts with the clinical algorithm and the associated materials, but even more importantly, from an experience perspective, is that in addition to the algorithm, we provide a narrative that is provider focused about why it is that our pathway, why it is that our experts who built this pathway, our clinical champion experts, are recommending the care that they're recommending and not doing the care that they're not recommending. And so a provider focused narrative of who qualifies for the pathway and what that care ought to look like. And that includes discharge criteria. How do we know when these patients are getting better and are able to begin that transition towards home and towards outpatient care? So provider facing materials, which allows us as the care providers, and this is not just provider, physician, and APPs, but this is for our nurses and our community liaisons as well, that we can say the same thing in very similar ways. So our patients and our families can see that we're on the same page, which enhances their experience. Many of our nurses will say that they know what comes next. They know when these patients are in the emergency department or when they're in the hospital, what's going to come next, and they're able to help the family to anticipate that. And then the same thing happens from an outpatient perspective, that our outpatient providers and our school nurses are also able to know what's going to happen and anticipate that and set appropriate expectations, what the family can expect when they're receiving care here. And then we also have patient and family facing educational materials that really is key for the patient and the family to understand what's happening, what's going on, why we're doing what we're doing, and what's going to come next as well. And hopefully as they look at these materials and read these materials, they also see things explained in a very similar way to how our narratives explain them. And so they also hear us saying things in a very similar way. They hear us saying something similar to what their primary care provider said. They hear their school nurse explaining diabetes in a similar way that we did. And they see that we're all on the same page and we all are on the same team taking the best care of their child or them. And we all are on the same page providing the right care at the right time at the right place. Okay, value. So we've also seen with our clinical pathways, as we were hoping to see as we began this journey, that if we reduce waste, if we standardize care, reduce variation, that this is going to lead to streamlined, most efficient care. And this is important not just from the resource perspective, but we also know that the more that we are able to reduce the time that patients are in the hospital or in the emergency department, the more we're able to prevent them from having unfortunate medical errors happen and the opportunity for these events to happen. And so there's so many reasons why streamlining care and being efficient with care is the right thing to do. This is just an example of our complicated appendicitis pathway. We started with the average length of stay of about 149 hours. And after implementation of the pathway, we've continued to sustain an average of about 85 hours or so. And so dramatically reduced that length of stay. And I also would draw your attention to the upper and lower control limits. At the outset of this, we could tell patients that in families that they could expect to be in the hospital anywhere from 5 days to 8, 9, 10 days. And now we've really narrowed those control limits as well. And we can give them much better expectations of what that stay is going to look like. And critically important to this, as we improve our resource utilization and become very efficient with the care that we provide, we're also able to reduce the inappropriate use of resources or waste, as the IHI would describe it, and as many quality models would describe it. I'm not going to go through the details of each of these pathways, but we have seen a sustained year over year, $1 to $2 million of savings every single year. And this is by not over ordering tests that don't provide any value to the patient's care, not overusing supplies that don't provide value to that patient's care, and really being very efficient with our resources around our nursing hours and our respiratory care hours. And then health of populations. As I mentioned, this is near and dear to us and our Pathways team about how we can really keep our patients as healthy as possible. And so when we first started our Pathways work, as I mentioned, we were building on our existing guidelines that were very focused on care that happens within our hospital walls, emergency department and acute care. And very quickly we realized that all of our pathways, patients are seen by their primary care providers, oftentimes before they're in our walls, many times after they're in our walls, and they have care that's ongoing. And in many of our pathways are for our chronic conditions like asthma. And these are patients that need that ongoing care. And the pathway, the patient's episode of care is not at all limited to the time that they are within our walls. And so we rapidly sought to expand the footprint of our pathways to include these other settings of care. And so we added on our primary care providers via a partnership with the Pennsylvania Pediatric Health Network and our primary care providers who are part of our clinically integrated network, and have been able to expand our pathways to include primary care components that are built by primary care providers with input from our subspecialists as needed. And also they get to see how our ED manages these patients and how our hospitalists manage these patients when they're admitted, and they can build that into the approach that they take in the primary care office. We, over the last year, have expanded our pathways to include our school nurses. And we now have multiple pathways that have school nurses as a part of that pathway team who are building the school nursing component of that pathway to be able to provide the ongoing post-discharge care while children and young adults are in school, with the goal of keeping them in school, successful in school, and as healthy as possible, both physically healthy as well as overall well-being and mental health by being successful in school. And most recently, we've had the opportunity to expand our pathways out to other UPMC hospitals where pediatric care happens. And this really helps us to provide the right care at the right time in the right place. Sometimes our patients are able to get the right care with the help of our experts here at Children's in Pittsburgh, but in their local community. And they don't necessarily have to travel 3, 4, 5 hours to come here. They can get the care locally where they live and their family lives and all of their support networks are. And we can help to drive that care, right time, right place, by expanding our pathways out to our service line. And so each of these settings of care may have a different clinical algorithm that's very focused on the care that happens in those settings. But what is really key is that the provider-facing and patient and family-facing educational materials are the same across the entire continuum. And this really is what's key to ensuring that we're all saying the same thing in very similar ways, so that our patients and our families see that we're all the care continuum and we're all working together to keep their child as healthy as possible. We've also been able to begin to build in ways to streamline this communication, build in ways that when a patient is in the school nurse's office and needs to have information from their endocrinologist who follows them for diabetes, build in ways to enhance that communication so that that child can stay in school and get the care they need from their school nurse and go back to class and be successful in school. So enhancing and streamlining communication across the continuum as well. As I mentioned, all of our pathways have representatives from each of these settings of care that are a part of this pathway team. And so our clinical champions include people from within our walls here at Children's, but also from our outpatient, both our UPMC and even our non-UPMC practices through our clinically integrated network in our school settings and even some other community settings. And the clinical champions are a part of our internal pathways team that includes a connection with our data team, includes a connection with our nurses and nursing informatics, includes our education team, and includes our finance team as well. And we're all working together to continually drive this care that we're providing that's the right care at the right time at the right place. We're very fortunate over the last year to have been able to partner with a new school nurse advisory group. This represents 25 school nurses and school nursing professionals from 8 different counties throughout southwestern Pennsylvania. And you can see, if you look at this map and look closely, those green dots where these school nurses are coming from. They're not just in Allegheny County and not just in our surrounding counties, but in some of our more rural counties as well, and represent the continuum of schools, and have been outstanding partners to help us to build pathways that make sense in all these school settings to keep our patients as healthy as possible and keep children in school and successful in school, particularly for our chronic diseases like asthma and diabetes. And there's a few others on here that you'll see for some of our pathways that we are working on will be released soon. And it's been a great partnership to have the opportunity to have our school nurses helping us with this. And in particular, they often will focus on the resources that they need in the school to be able to help to manage the chronic conditions and the acute exacerbations that happen with these chronic conditions for our patients and families and the students in their school. And I really want to highlight our newest G-tube maintenance and troubleshooting pathway. This is a brand new pathway that initially came to us as a request to build the post-operative feeding component after a G-tube is placed. And very quickly, our pathways team and our clinical champions recognized that there's a lot of patients who have a G-tube who are out in the community, they're going to school, they're in their primary care office, and there's a lot of issues that can come up with the G-tube, and not all those issues are going to necessarily necessitate a visit to the pediatric surgery office or an urgent care visit or an ED visit or an admission. And there's actually a lot of troubleshooting that we can provide to our school nurse partners, our community partners, our primary care partners to help them to be able to take care of these issues when they arise, and then keep kids in their community and keep kids back in school and get them back to the class and back to the athletic events and other school events that they're doing. And so I think this is a great example of how we can share these resources across the continuum to really provide that absolute best care, the safest, highest quality, most high value care to our patients and families, and certainly enhance that experience that now our patients can go to their school nurse or go to their primary care provider and know that they are very competent at being able to handle some of these complications and troubleshooting issues that come up around G-tube stoma and G-tubes, and can do what our experts recommend, but in their local setting of care. Okay, and then the newest aim that transitioned the quadruple aim to the quintuple aim is health equity. And so this is a new area that I still believe have a lot more opportunity to continue to grow in this, but I just wanted to show one example of some of the work that we're currently doing. This is our outpatient asthma dashboard, which is one of our newest dashboards, and has been a great partnership with our asthma center, as well as with our pathways team and with numerous clinical champions throughout our organization, including primary care and school nurses as well. And we can use our dashboards to perform geoanalytics on zip codes that we know are zip codes that tend to have underserved patients and families, tend to represent underserved communities. And we're able to hone in on where are patients who are having acute asthma exacerbations necessitating an ED visit, where they're coming from, and hone in on these zip codes where we're seeing that there's a high number of patients coming to the emergency department. And then on a weekly basis, we're actually pulling these patients from these zip codes who came in for an acute exacerbation and providing it to one of our community partners under our UPMC Children's umbrella, our family care center nurses, who are able to connect with these families, connect with the families. Sometimes that's a home visit. Sometimes they are able to connect with them and bring them to one of their FCC sites, but are able to make that connection in the community to help to ensure that we are adequately addressing the unique needs that they may have, and providing them with the right resources and support to hopefully keep them healthier and keep them from having these acute exacerbations and needing to come to the emergency department. So I think this is a great first step. I think we have a lot more opportunity to continue to support our outstanding health equity work that's happening throughout the organization with our pathways to help to drive that, as we have with quality and safety as well. And so linking this back to where we started with the quintuple aim, I really think that our pathways help us with this clear plan of care. They help us to have a clear plan of care and make it really easy to provide the absolute right care that's the safest and highest quality care. And that helps to provide a good experience for our patients and our families. Our pathways allow us to measure performance and outcomes, both internally as well as across the board, and ensure that we are building the right services and support to keep our patients and our populations as healthy as possible, keep our patients out of the emergency department, keep them in their community, provide the right care in their community, and keep them in school and keep them overall well and as healthy as possible. Certainly, our pathways have helped us to improve our efficiency and reduce waste. And that's important for resource utilization, and that's important for safety and quality and well-being as well. I think our pathways with our provider-facing narratives, our patient and family educational materials, and then sharing this across the continuum really helps to drive the patient and family experience and caregiver well-being and caregiver experience. And then building in ways that our pathways can support our health equity work, because equity is a critical component of quality and a critical component of the quality aims. And so here's just a preview of where we're going with our clinical pathways this year, as well as a couple of additions and revisions. Asthma is going to be a big one. There's some, as you all know, some new revisions to the maintenance therapy of asthma, and we're building that into our pathway, and particularly partnering with our primary care providers and our school nurses around that, and continuing to drive the equity work that we're doing around asthma as well with our partnership with the Asthma Center. So an exciting year coming up as we continue to expand our clinical pathways work, and all of these will expand across the continuum using the model that I described this morning. We are very, very fortunate to have a tremendous team of people who help us to do this every single day. This includes partnerships with our Division of Health Informatics and Nursing Informatics and Health IT. This includes our partnerships with our Pennsylvania Pediatric Health Network, with our community division of community health. And I would venture to say that 2/3 to 3/4 of all of you who are listening in today have probably been on our pathway teams and have been a clinical champion. And we're most appreciative of all the work that you do to drive this every day. I have the honor of facilitating this work, but it really is all of you who drive this and make this happen. So a huge thanks to everyone who helps to drive this and supports us in this work. And couple of references, and thank you again in particular to the Christensens, Michelle and Maddie, for this opportunity. Most appreciative, and I hope that this was enlightening with some of the work that we're doing, and happy to address any questions. Thank you.
Thank you, Andrew. And appreciate I think it was a really nice past, present, and future in terms of our journey with pathways, its relationship to patient safety, and the newly released quintuple aim. We do have some questions in the chat. The first one's from Dr. Chavez-Neko. And he just says, thank you to the Christensen family and Dr. Bucher and the team for all the work that's been done for patient safety. Could we please talk about any efforts made to assure patient safety in non-English or limited English speaking patients in our hospital and at other UPMC other than the use of certified interpreters? What are we doing to improve communication in relation to patient safety? Thank you.
Yes, great question. What I will highlight is that we are early into this work, but this is certainly critically important. We're fortunate that our Pathways team has partnered with the work that, in particular, Maria Said and Sisson is doing around language access, and partnered also with the work that's happening from the system level at the Wolf Center around expanding our, not just language access, as you mentioned, interpretation and translation, but the much bigger picture that there are very unique opportunities for us to ensure the highest quality and safest care for patients who have a language other than English as their preferred language for healthcare discussions. This includes translating the consent forms. This includes making sure that our patient and family facing education is provided in the language that is their preferred language, all in addition to ensuring that the conversations that are happening with an interpreter or with someone who is able to competently provide that in their preferred language. I do foresee that our Pathways can help to drive this. This was a hot topic recently at a Children's Hospital Association quality leaders meeting last week, and I think that this is something that we all share in the drive to build this into our quality work. This is a critical component of equity, and build this in and ensure that the work that we're doing around safety and quality begins to address this. So I think there's a lot that locally that is going to be happening on this. Some great efforts that have been started already, but a lot more to come. And I'm hopeful that we'll all be able to make some good advances in this over the next 12 months or so. I think there's a lot of energy around doing this. So totally agree, it's a huge opportunity.
Thank you. Our next question is from Christine March. With the inclusion of school nurses in clinical pathways, is Children's considering electronic HIPAA compliance systems to facilitate school nurse provider communication? Using phones and fax is clunky, to say the least, and remains a challenge in addressing school health needs.
That's a great question. I can tell you that in the school nurse advisory group, that's their number one item, is how do we facilitate this communication. We are in the midst of working through some of these very unique challenges in our system where the school nurses are employed by the school systems, and some of the legal and regulatory challenges that we need to make sure that we're adequately addressing as we do this. But we're beginning to explore some options. Ideas that have come up include potentially ways maybe the portal could help us with this, and ways that health information exchanges could help us with this. So lots of work happening around this, but I think that what's most important is that this drive is there on both sides of this. And so we are absolutely committed to finding a way to enhance this communication.
Thank you. The next question is from Anna Radovic. Thank you much for this important work, Dr. Bucher. I'm wondering if there's been consideration of moving clinical pathways from the infonet to the internet to make it easier for providers outside the system, as well as patients and families, to see all or at least overviews of our pathways to increase access and transparency. For example, Cincinnati Children's has this practice.
You read my mind. A couple of folks on our Pathways team have just heard me talk about this recently. So we're having the exact same thoughts. And again, I think we have a couple of steps that we need to work through as we operationalize this, but particularly as we partner with non-UPMC entities who don't have access to the InfoNet. And we also know that even in our primary care settings who do have access to the InfoNet, it's not a part of their workflow to use it as readily as we do here within our walls at Children's. And so we have some ideas about where we might go with making our pathways and guidelines available outside of our walls. And I have recently heard about some other unique opportunities that other organizations are using with handheld technology and apps to help with this as well. So great question, and more to come on this one also.
Yeah, there really is a great question. And I think in general, you know, we do have a culture of transparency around these things. I think we need to, where there's some legal hurdles and some other things that we need to address, but I think it's a really good point for us to make these as widely available, and other institutions are doing the same. Our final question this morning is from Dr. McCormick. When we think of equity, there is an important concept of centering on the margins, meaning we move to amplify the voices of individuals most at risk. I see the inclusion of school nursing as a starting place, but is there movement in UPMC Children's to prioritize working with nonprofits in the communities where the most marginalized community live and amplifying those voices?
Yeah, great question. You know, I think our Division of Community Health has really been an awesome partner in this, with identifying where these opportunities are on the margins and where these organizations are. And Anne-Marie Kuchera and her team with Dr. Liz Miller have really been great partners around this. And we are absolutely excited from a Pathways perspective to expand this work further out into the community, and you know, do whatever we are able to do to partner with these groups to be able to expand this population health approach. And so absolutely, the answer is as much as we are able to, that's exactly where we want to move to and what we want to do. And we're very, very fortunate to have this great collaboration with community health to help us to be able to operationalize that.
Very well put. With that, that actually concludes our questions. I want to say thank you again to Dr. Bucher for a great talk this morning, and sincere continued thanks again for the Christensen family for your support of us here at Children's as we continuously work to make our environment safer for all. With that, that'll go ahead and conclude this morning's Pediatric Grand Rounds. Thank you everyone for your participation. Take care and have a good day.